Moving on to the left upper quadrant. So this is the left upper quadrant positioning. You place the probe at about the posterior axillary line and in the 6th to 7th intercostal spaces. And on the left here is the view that you want to see. You want to see spleen and kidney, and then you can see the diaphragm is marked with arrowheads in that picture there. So that's sort of the canonical view you want to see. And in the right upper quadrant, we looked for fluid between the liver and the kidney. In the left upper quadrant, you can find fluid between the spleen and the kidney in that same sort of potential space, but you also want to look all the way around the spleen for fluid before you kind of rule out fluid in this quadrant of the abdomen. So this is a kidney as seen in the left upper quadrant. This is a 20-year-old female, and she had pyelonephritis on the left, and she'd been receiving antibiotics for 6 days, but it wasn't resolving. She had no significant past history. She had normal renal function, and when they looked at her kidneys, they found that she had all these cysts in her kidneys, and one of the cysts you can see has sort of a little bit more poorly defined margins, and it's enlarged, and in this cyst she has some infection that's been sort of sequestered away from the antibiotics, so it's been able to survive the antibiotics. This is another case where you can look at the relative sizes of organs. So this is a 60-year-old male. He has hepatic cirrhosis that's known. And when you take a look in his left upper quadrant, you can see that his spleen is significantly enlarged, which suggests that he has some portal hypertension because the splenic vein enters the portal system. And for comparison, here's a normal-sized spleen relative to the kidney. So as you perform these exams, you can get used to the normal textures of the organs and the normal proportions of the organs one to another. And so if you were to look at this person's spleen without having any prior knowledge of their past history, you could say, maybe there's something going on here, that their spleen is so enlarged. And again, another case where you can look at the relative size and textures of organs. So on the left we have the image of a lady's kidney. She was something less than 70, close to 70, but something less than 70. This is her kidney. She had hypertension and diabetes, and 10 years later, this is her kidney on the right. You can see it's almost shriveled up, It's the renal cortex is almost completely obliterated, and most of what's left there is just the fat that exists in the core of the kidney. And so this lady is on dialysis at the time of the image that was taken on the right there.
So here's an example of lung sign number 4, what we call a consolidation pattern. Here we have a pleural view on the left side with diaphragm, spleen. We have a solid organ density above the diaphragm here, which represents a completely collapsed left lung. Now, the etiology of consolidation is the de-aeration of that lung, whether it's complete atelectasis or if it's pneumonia that has replaced the air with fluid and pus, is a matter of clinical correlation. And there are some ultrasound signs that many will speak of that can help you distinguish between them, including dynamic air bronchograms. We're not going to get into that today. Really, just the bottom line is if you see unilateral consolidation, somebody with a fever and a white count, I'd favor pneumonia. If it's bibasilar consolidation, a patient who's been ventilated for a few days and is otherwise afebrile, I'd favor atelectasis. So you do have to correlate it clinically, but often very helpful finding in patients with otherwise undifferentiated respiratory failure, because even a degree of this much of consolidation is often occult to chest x-ray, you'll find. So here's another example. Again, nice picture here of spleen, diaphragm, and collapsed atelectatic lung, appropriately though, because you can see how it's encased in fluid. And to diagnose pleural effusion, you really need to see the chest wall. You need to know that you have a diaphragm. Really, you must identify the diaphragm. Not everything that's black and near the chest is an effusion. And you have to see dynamic signs. You have to see the diaphragm move or the lungs start flapping to really be sure that that's an effusion, in particular when you're looking to stick needles in it.